This session is actually amazing. The first speaker, is our Tiger Woods, Dr. Lenke. So it's amazing, Dr. Lenke. It's a pleasure for me to bring you on the stage. He's going to actually talk what really matters in here, What is the future of spine surgery and how he sees it from the ortho point of view. Dr. Lenke, welcome.
Thanks, Juan. Appreciate it, an opportunity to speak today. So, my disclosures. I'm going to stick in my lane, talk mainly about spine deformity surgery. I will have actually some thoughts that I've accrued from Alex Vaccaro, someone I really, really admire on spine surgery in general at the end of this. But regarding spine deformity surgery, kind of where it's been, I always think it's good also to think about where it's been to where we're going. So let's take the 50-year spread, covering these 8 topics, starting with imaging. So here's 2000, imaging of our patients. Obviously, by 2025, we're looking at the whole body. But still, these are static images. By 2050, we'll probably still have static images, obviously, but minimal to no radiation. I think MRI scans are still going to be present, but CT scans are going to be obsolete. But the key is we're going to have dynamic spine and body assessments. It still kind of amazes me in 2025 we're not doing dynamic imaging to assess the spine before we treat it surgically. So that's definitely going to change. We'll have sensor technology, obviously, that will help us give information to the spine, spinal column, and the rest of the body on how to treat patients. And so surgical treatment will be aimed at not only optimizing alignment, but optimizing function, which is something that we need to do, obviously. Pre-op planning and alignment goals, we have a lot of alignment goals that have come up by now 2025. We're not quite sure exactly which ones are best. I really like these new vertebropelvic angles. I give a shout out to Mike Kelly and Jeff Hills. I really think there's something really positive about this. And so we're using these now, obviously, to optimize our patients during complex surgery with our overall global alignment goals as well. But our targets for 2050, I think, again, as Juan mentioned, everything's going to be AI-based, and I think it'll be very individualized, segmental, regional, and global targets for each patient. We'll have definitely intra-op confirmation. You won't leave the OR, and you probably won't be allowed to leave the OR without these targets being met. And with these, then, I think we'll be hopefully decreased adjacent segment problems if we're still fusing the spine, as I'll talk about later. And also, we may find that our targets are going to be tied to reimbursement. If you don't meet your targets, you're not going to be paid. So guess what? People are going to meet their targets. And that's, I think, an issue that's been with degen surgery is that, to do a really good job in a short fusion, you have to spend a little more time sometimes, and there's no extra reimbursement for that, right? So we have to change the model to be a little more value-based. For planning, obviously we're doing planning now on our degen scoli patients, both with many different planning softwares that are available. You can use a patient-specific rod if you want, do the surgery, and then can kind of confirm both the fused and unfused spines if you met your alignment targets. Obviously, AI is kind of telling us what's going to happen in the unfused region. It's getting better and better with better data, obviously. So that's going to continue on in the future. So these AI-based planning software will be patient-specific. With patient-specific implants, will provide both correction of deformity alignment and maintenance of realigned segments. The intra-op placement of these materials will be predetermined to minimize implant failure over the activity level and lifetime of the patient, so it won't be a one-size-fit-all, I think, type of implants. And it will be early warning signals. Now, if there is an issue coming up, that we'll know about that ahead of time, so there won't be any implant failure because we'll basically be able to intervene before that happens by 2050. Patient selection optimization, we're doing that now, obviously. Most centers have patient optimization teams, so we make sure we take especially our older adult deformity patients and optimize them before surgery. We kind of have that at our center where you proceed, optimize, or don't allow surgery in patients who are too frail or not healthy enough to tolerate the surgery. Right now, insurance companies are not involved in a medical optimization component, obviously. They're involved in other parts, as Dr. Uribe mentioned, but not that. But certainly, most of us, even now, won't take a patient like this and to go directly to surgery for an elective deformity reconstruction until these patients are optimized. By 2050, definitely, I think all kind of EMR data is going to be automatically placed into a patient pre-op clearance app, which will basically need to be completed before the patient is allowed to go to surgery. And then obviously, it's going to be driven a bit by the insurance companies as well, which is probably a good thing. And obviously, sensors are going to be tracked to confirm the patients are optimized as well. And there will be kind of minimum requirements mandated by the payers for proceeding with surgery. That's definitely, and maybe that's a good thing that we're operating on on patients when they've been optimized. And then continuous remonitoring post-op, obviously, to help predict and avoid complications by being proactive with them. Anesthesia improvements, obviously, up to in the last 25 years, the use of things like TXA has completely revolutionized at least open deformity surgery. So we can basically do a complex T2 to sacrum reconstruction with this kind of exposure and minimal blood loss with almost unheard of a patient getting coagulopathic now during surgery. Where back in the 90s, we had a stage often complex adult deformity surgery because of impending or actual coagulopathy. This just doesn't happen anymore because of newer techniques. By 2050, these anesthesiologists are going to have AI algorithms that optimize anesthetic regimens, optimize MAP levels during the whole surgery, optimal levels of fluid resuscitation. Hopefully, we'll get faster wake-up tests. I think that would be the best thing in the world. Patients wake up right after surgery. We don't wait. Probably minimal to no ICU post-op because of all these improvements. And post-op meds, intra-op and post-op meds to decrease or eliminate ileus, VTE, delirium, things like that. Neuromonitoring, obviously, has come a long way as well. We have now consensus guidelines and these very complex algorithms that are published to help us kind of sort through neuromonitoring changes. That's great, but that's not ideal, obviously. We need to kind of avoid that and actually have AI interpretation of the data ahead of time, which will give faster warning of neural impairment. And real-time monitoring of spinal cord nerve blood supply also may be possible and helpful as well, not just electrical activity of blood supply. Intraoperative monitoring alerts hopefully will provide possible AI responses and curative measures simultaneously. So you not only be alerted there's a problem, but give potential solutions to that problem, which is what we should do now. Obviously, we do that individually now, but that will be provided, I think, to surgeons across the world to help make spine surgery neurologically more safer. So things are more proactive than reactive, which obviously will be much better. Intraop techniques, so 2000 was the age where we learned how to place pedicle screws into deformity and made a huge change in our profession. Since that time, we're still basically obviously placing screws as our main anchors. We're doing it for different techniques now, obviously. By 2025, the open posterior approach is still predominant, but obviously, as you're all well aware, much increased role for MIS anterior and posterior approaches and ALIFs as well. Robotics is quickly becoming increased adoption around the country and world. A bit of financial challenges with that, though. Still kind of a little bit limited by a robot placing kind of one screw at a time, which seems a little bit limited in the future, that we need to be placing kind of cartridges of screws into these segments, which will be much more efficient. And we're still obviously getting pre- or intra-op CT scans and radiation involved with that, which hopefully will become obsolete very quickly. So I predict by 2050, most primary surgeries will be done by MIS, either anterior, posterior, or lateral, however you're coming in, but not through open posterior approaches. There will still be probably a role for some revision surgeries being done, open posterior. The question is, will we still be doing fusions? Obviously, the holy grail of long-term deformity correction is with continued spinal motion. We haven't found implants to allow that to happen consistently, at least in the adult world. Tethers have definitely play a role in the pediatric world, but have not had as great a success in the adult world. But again, hopefully with biomaterial improvements and again, AI working out exactly the forces involved and the motion of patients, maybe we can get to a state where we're not doing as many fusions and keeping the deformed spine corrected without fusion. That certainly is a holy grail. And then that really benefits muscle sparing approaches where we keep the muscles more active and usable because again, the spine's still moving. And again, hopefully by that time, if we're placing screws or implants, robots are placing multiple implants simultaneously with live navigation, so we know exactly where things are on. And I predict pretty soon that every instrument implant is going to be navigatable. So nothing's going to be put into the spine field without being lively navigated. That's going to come sooner than later. Post-op care, early mobilization. I think I've had 7 patients now go home post-op day 1 following a deformity surgery, typically in teenagers or young adults with selective thoracic lumbar fusions. I know Hanjo Kim has had patients go home from the recovery room from a T10 to sacrum. So obviously better anesthesia, better care, less blood loss, and patient preparation, that's going to be possible. By 2050, there's obviously going to be mainly outpatient surgery, even for deformity surgery potentially. Some will still need multi-night stays as as well. But again, there's going to be patient-specific post-op care algorithms developed to direct post-op care to optimize their care and minimize hospitalization and cost and hopefully complications. I think post-op ileus is going to be eliminated, hopefully, and there will be non-narcotic pain management will be standard of care. Patient-specific physical therapy protocols, again, individualized for the patient specifically. VT prophylaxis will be universal and successful and patient-specific. And a 30-day and 90-day return to OR and return to hospital rates should approach zero through all this algorithm and treatment decisions. So what about our outcomes, both radiographic and clinical? So we all owe a debt of gratitude to Keith Bridwell, started the ASLS study, which confirmed over now up to 8 years follow-up the superiority of operative versus non-operative care for adults with symptomatic lumbar scoliosis and the durability, the top line durability of the surgical treatment group as well. Overall, are we making improvements in the last few years? I think the answer is yes. In my own personal results, my PGF rates, so revision of my own patients for PGF the last year, 0%, 3 years in a row, knock on wood, usually between 1% and 5%. Implant failure, shoot arthrosis rates, nearly 0% the last 3 years. And upper thoracic, the sacrum reconstruction is the most challenging, 0%. So we are starting to bend the curve already. Obviously, we're not where we need to be, but again, using these techniques, we're working with our computer scientists to develop machine learning algorithms to predict, again, who's going to be at risk for having complications and post-op, that we're getting all better at that as well. So spine deformity 250, emergence of dynamic imaging, as I mentioned, individualized patient preparation, be optimized maximally before surgery, intraoperative technologies for all aspects of the surgery, and individualized post-op care patterns. And these predictive modeling loops will be involved in all aspects of care, from patient selection all the way down to post-op physical therapy protocols. So I asked thoughts from Hanjo Kim. I wanted a different perspective, just to make sure I wasn't missing a boat on any of these. He actually agreed with almost everything I said, including he thought kind of labs won't be drawn anymore. There'll be sensors that'll be drawn from the skin, so patients can get continuous monitoring of their data. He thinks Center of Excellence will be developed by 2050, where payers will resort to that. Quantum computing will make a difference, obviously, and basically, as I mentioned, no opiate use as well, and discharge from home following surgery, from the majority of surgeries done, even deformity surgery. So marked changes. So 100 years of scoliosis treatment, there we were in 1950, 2000. Will we have a DNA manipulation of a scoliosis gene to ameliorate scoliosis? Possibly not, but who knows? That could be the future of deformity surgery. Give me another 30 seconds, some thoughts from someone I really admire, Alex Vaccaro. Two things he mentioned: endoscopy. He thinks it's going to change the way we do degenerative lumbar and cervical surgery. I think many of you are aware of this. Again, I'm a novice in this. I know a little bit about it, but obviously I don't practice this. Certainly in vogue, the amount of literature, and this is actually 2020 data, but it's even doubled the amount of publications per year, and endoscopy is increasing dramatically. So his thoughts are, with push to more MIS surgery, certainly more surgeons are going to be adopting to do this. We'll push indications, but we have to somehow flatten the learning curve. There's certainly a pretty steep learning curve initially, so we have to flatten that. The other thing that Juan mentioned as well, non-surgeons performing spine surgery, a big concern. So who's going to be doing spine surgery in 2050? Hopefully it's neurosurgeons and neurosurgical spine surgeons, but there's going to be, as the trend towards less invasive surgery goes, spine interventionalists, that's their territory. So I think that's something we have to really all be mindful of in the future. So I thank you for your attention.